Dr. Lagnanden, one of our registrars. Dr. Lagnanden, good morning, and please start.
Thank you, Dr. Abhinisa. Good morning, everyone. So I'm Dr. Abhinandan. I'll be presenting the first article today for Journal Club at OrchiCan. So the article is a comparative study between the roles of intrauterine misoprostol versus the sublingual route for prevention of postpartum blood loss in elective cesarean sections, a randomized control trial. So it was a study by Adele et al., published in October 2024 in the BMC Pregnancy and Childbirth. So a little bit about the background. Globally, PPH is a major contributor to maternal morbidity and mortality, with an incidence ranging from 6 to 10%. It is thought to be the direct cause of 25% of all female mortalities. Uterine atony at vaginal delivery or seizure is the most avoidable cause of PPH, and it has an estimated amount of blood loss during PPH averages to more or equal to 500 ml in vaginal birth, more or equal to 1000 ml in seizure, and around 3500 ml in emergency hysterectomy. At seizure, oxytocin is the most commonly given to avoid uterine atony and excessive hemorrhage. Extra-uterotonic medications are still required in about 10 to 40% of cases in order to be able to achieve adequate uterine contractions. Most common supplementary agent is prostaglandin E1, misoprostol, and it attaches to prostanoid receptors, promoting strong uterine contraction. So a bit about the PGE1. Pharmacological activity on uterine muscle fibers involves powerful myometrial contractility, starting at the fundus near the cornea and progressing throughout uterine body, compressing uterine vessels and thus reducing blood loss. PGE1 is appropriate for global utilization, including low resource settings. It has a convenience of administration, thermal stability, a reasonable price and availability. It can be administered orally, sublingually, buccal, vaginal, rectal, or intrauterine. It has a better absorption when taken sublingually than oral or vaginal, and sublingual administration has been investigated and proven as effective for PPH prevention. The rationale for this study, the intrauterine use of misoprostol is closer to the targeted organ, which acts as an autocoid substance with a stronger impact. As a result, the intrauterine route may be more effective than alternate routes. The aim of this study was to evaluate the effectiveness of combining the use of intrauterine misoprostol with oxytocin intravenous infusion to reduce intraoperative blood loss and prevent PPH at elective cesarean section. The primary outcome was the estimation of amount of blood loss during and after the seizure, and the secondary outcomes was incidence of PPH within the first 6 hours after labor, need for blood transfusion, need for supplementary ecbolic drugs, need for additional surgical intervention for PPH, changes in hematocrit and hemoglobin in both groups after seizure, and the incidence of side effects of the study medication. So in terms of the study design, it was a prospective randomized control trial done at the Labor and Delivery Unit at Qasr Al Aini Hospital in Cairo University. It was done during January 2022 up until February 2023. Reporting followed consolidated standard of reporting trials guidelines, and research approval was obtained from the Scientific and Ethical Committee of ONG department at Cairo University. So the study population inclusion criteria for pregnant women was age between 20 and 35, BMI of less than 30, full-term singleton healthy live fetus, gestational age of more than 39, either confirmed by LMP or by dating scan done in the first trimester. And they had to be candidates for elective cesarean section, with the indication being 1 or 2 previous seizures. Exclusion criteria, uterine distension due to multiple pregnancies or polyhydramnios, multiparity, more or equal to 3, uterine fibroids, antepartum hemorrhage presentation in terms of previa, abruptio, or vasa previa, moderate to severe anemia with hemoglobin of less than 9, anticoagulant use in pregnancy, and coagulopathy, thrombocytopenia, or blood dyscrasias. Other exclusion criteria was also hypertension, cardiovascular, hepatic, or renal disorders, diabetes, any contraindication for the use of misoprostol or oxytocin, such as allergy to prostaglandin and concomitant drugs, and any drugs that have interaction with prostaglandins. In terms of the randomization process, randomization schedules were created by computer programs and were designed and set in serially numbered, secured opaque envelopes. A simple randomization process was used, 1-to-1 ratio within both groups. Participants opened sealed randomization envelopes to reveal allocation and assign sequential numbers based on admission. So in terms of the method, the study purpose was clarified simply in local language to all women before they were registered for the study. Informed consent was obtained. All participants were subjected to comprehensive medical history in terms of obstetric, medical, and surgical. They were subject to general examination, systematic obstetrical examination, transabdominal ultrasound to evaluate fetus, and blood samples in terms of complete blood count, coagulation studies, liver and kidney function tests. So the eligible participants were randomized to 2 groups. The first group were given 400 microgram intrauterine misoprostol, and the second group was given 400 microgram of misoprostol as well, but sublingually. And they also received oxytocin intravenous as per protocol. Both groups were subjected to the same preoperative preparation, spinal anesthesia, and antibiotic prophylaxis as per that hospital's protocol. Elective caesar at 39 weeks was done by the same team, senior obstetric gynecologic resident. Caesars exceeding 90 minutes from skin to skin were excluded. In terms of operative steps, on the skin, transverse incision was made, lower uterine segment, Smiley incision. After fetal head extraction, participants in both groups received 5 units oxytocin as an intravenous bolus and an infusion of 10 units of oxytocin in 500 ml of Ringer's lactate at 125 ml per hour. Subsequently, cord clamping was done within 30 seconds, placental extraction after spontaneous separation. Group A, surgeon placed 2 intrauterine misoprostol tablets, 400 microgram in total, at the fundus after placental delivery and after swabbing the cavity, followed by suturing of the first layer. In the group B, 2 sublingual misoprostol tablets, also 400 microgram in total, was given after placental delivery sublingually. The uterus was closed in 2 layers and abdominal closure anatomically in layers afterwards. Adequate hemostasis was secured. In terms of the liquor, it was collected in a separate suction tube after uterine incision. So in terms of the study measurements, blood collection was recorded in separate suction tube after delivery of the baby. Surgical towels were weighed before operation and after operation with a 1 gram difference taken to be equal to 1 ml of blood. Blood collection drapes were used during the first 6 hours postoperatively. Estimated blood loss was calculated by adding the volume of blood from the suction tube, from the towels, and from the collection drapes. 24-hour postoperative hemoglobin and hematocrit level were also taken. They also use a formula-based estimation for estimated blood loss, which was estimated blood loss was calculated as the estimated blood volume multiplied by the difference between pre-hematocrit and post-hematocrit divided by the pre-hematocrit level. So in terms of the sample size and power, calculation of sample size was performed by G-Power software of this name. This possible sample size was 96 women in each arm to be able to reject the null hypothesis by their students' t-test for independent samples with a power of 90% at an alpha level of 0.05. So this diagram represents the randomization and allocation of the participants. So in total, there was 285 patients assessed for eligibility, of which 93 were excluded. 81 did not meet the inclusion criteria. 12 of them declined to participate. So in total, 192 candidates were randomized into the two groups. So 96 allocated to the intrauterine 400 milligram misoprostol, and 96 were allocated to the sublingual mode of delivery for the misoprostol. There was no candidate lost to follow-up and no one who discontinued, and all the data was included in the analysis. So in terms of statistical analysis, data was reported in different manners: means, median, ranges, percentages, and frequencies. Student t-test compare numeric values, chi-square test to compare categorical data. Two-sided p-values of less than 0.05 was considered statistically significant. Statistical package for the social sciences, SPSS computer program, was used for statistical analysis. So this now for the results. So this first diagram demonstrates the demographic features of this study. So some of them considered age, gestational age, BMI, parity, number of previous users, number of abortion, and positive previous surgical history. So there was no significant difference in age, duration of pregnancy by date, ultrasound, parity, number of previous users, or positive previous surgical history between the two groups. So there was demographic homogeneity in the two groups. The BMI and the number of previous abortions were significantly greater in the intrauterine misoprostol group than in the sublingual group, but these were statistical difference with no clinical influence, as they were irrelevant in the context of this study. So this table demonstrates the results for the primary outcome. So it's a comparison between mean value of preoperative, postoperative, and difference in HB and hematocrit between the study. So we'll start by looking at the first two lines, which compares the preoperative hemoglobin in both groups. And we can see that they had no statistical difference between them, which means that they both equal in both groups. The hemoglobin and the hematocrit level started at an equal baseline. So in terms of the post-operative hemoglobin, we see that the post-operative hemoglobin was 10.5 plus minus 1.0 gram per deciliter in the intrauterine group, and it was lower in the sublingual group, which was 9.9 plus minus 1.1. So they didn't actually include the actual difference in their data, but we can infer from those values that there was a post-op hemoglobin difference between the two groups of 0.6 gram per deciliter. And regarding the hematocrit, for the intrauterine group, it was 32.2 post-operative in the intrauterine group and 30.8 sublingual in the sublingual group, which is also a difference of 0.6%. And both p-values for this post-operative data are significant. One is less than 0.01, the other one is 0.02. Now for the HB difference in terms of pre-op versus post-op. So we can see there was a drop in hemoglobin level in the intrauterine group from pre-op to post-op of 0.8. versus 1.2 in the sublingual group. So again, that difference comes up to around 0.4 gram per deciliter difference in the sublingual group for the hemoglobin. And for the hematocrit percentage difference in the intrauterine group, it dropped by 2.3 plus minus 0.6 in the intrauterine group, and in the sublingual group around 3.1 plus minus 1, which also we can infer from that there was a difference of 0.8% more in the sublingual group, and both those data were significant. So this table compares the operative time, blood loss in soap towels, and blood loss in suction jaw, mean value of estimated blood loss by the formula between the study groups. So what we can see is there's an absence of significant differences between the two groups in terms of operative duration and content in the suction unit post-operatively. But the blood loss caused by soaked towels and the estimated blood loss calculated by the formula was significantly lower in the intrauterine misoprostol group than in the sublingual misoprostol group. So again, we can infer from the blood loss by the soaked towels was 80 ml more in the sublingual group. And from the suction unit, it was 12 ml more, and it was not considered statistically significant. Whereas for the estimated blood loss formula base, there was a 147 ml difference more in the sublingual group, and that was statistically significant. In terms of the results, so those were the secondary outcomes. So the side effects occurrence in study groups, use of extraembolics, need for blood transfusion, need for additional surgical intervention for PPH, and blood loss of more than 1,000. So from the post-operative data, there was no significant difference between the groups regarding blood loss of more than 1,000 ml during the first 6 hours. There was no difference in terms of need for additional embolics, need for blood transfusion, further surgical intervention for PPH. And there was no significant difference in terms of side effect profiles or their incidence when comparing the modes of administration. So we'll talk a bit about, we'll discuss a bit. So prevention of PPH and minimizing intraoperative blood loss are the main concerns of all obstetricians during Caesar. Powerful myometrial contraction plays a fundamental role in controlling uterine bleeding through squeezing uterine vessels. Misoprostol possesses adequate embolic effect that can be used for management of PPH. In terms of the physiology, PGE1 acts mainly on eprostanoid receptors, and there are different types of eprostanoid receptors. There's EP1, EP2, EP3, and EP4. EP3 and EP1 both work at the fundus and corpus. That's where the PGE1 is acting to bring about the uterine contraction. And it is at lower density at the lower segment and cervix. So just of note, when we use PGE1 when for cervical ripening, it acts on a different receptor and works differently than what we are speaking about in this context. So data analysis from this study showed a statistical difference in intraoperative blood loss in hemoglobin and hematocrit drop after Caesar in favor of less blood loss in the group using intrauterine misoprostol combined with oxytocin. There was no significant difference in terms of the secondary outcomes, as we said before. So the study strength, the study was adequately powered and it was a randomized design. The study weaknesses, it was difficult to ascertain the amount of misoprostol that is actually acting on the MP3 receptor at the fundus versus the amount being washed out with the lochia. It was a single blind study, and it was unclear if there was any incidental findings of fibroid intraoperatively, and if extra steps like uterine artery ligation or compression sutures were done in any of the cases, and if so, were the data reclassified in terms of eligibility for analysis and interpretation. So in terms of the guidelines, the FIGO guideline regarding prevention of PPH of 2022. So in the green square, there is the part where they speak about misoprostol. So they report the use of misoprostol plus oxytocin may be effective uterotonic drug strategy for prevention of PPH compared to the current standard of using oxytocin alone. But this comes at the expense of a higher risk of adverse effect in terms of vomiting, and fever. In terms of treatment of PPH, the role of misoprostol is only when oxytocin is unavailable, and it should be used sublingually, 800 micrograms, and there's no evidence about the safety and efficacy of an additional 800 microgram misoprostol after it was already given the first time. So in terms of the local guidelines, SASOG 2019 preventive measures against PPH. So they mentioned at CSER the use of intravenous oxytocin 5 units bolus or carbetocin 100 microgram IV. And the National Integrated Maternal Perinatal Care Guidelines of last year, they mentioned for prevention of intraoperative PPH, 2.5 units of oxytocin IV over 30 seconds after delivery of baby, and the rest, the 7.5 units in the drip, and to repeat the 2.5 bolus if there is poor uterine contraction, followed by the delivery of placenta by contraction, good surgical technique. And post-op prevention, oxytocin infusion, 20 units per liter for 8 hours, plus minus symptometrin if needed. So what's the relevance of this study in terms of PPH at CSER in the context of South Africa? So these data are from the Saving Mothers Annual Report 2023, where we can see the obstetric hemorrhage ranks 4th in the primary obstetric causes of death. And if we see in terms of breaking the category of obstetric hemorrhage, PPH at or after cesarean delivery accounts for 28.1% of all that obstetric hemorrhage. So in terms of KZN, the most common underlying cause in KZN was obstetric for maternal mortality was obstetric hemorrhage, but that was inclusive of APH, PPH, and both vaginal and cesarean delivery. And while KZN has the highest cesarean delivery rate at 38.4%, it is among the 2 provinces with lowest case fatality rate in terms of cesarean delivery. But the cause there in those data is not specific to obstetric hemorrhage. That's all. Thank you.
Good morning. Thank you, Dr. Labnan. I'm just going to make 3 points before I take any questions or comments. In terms of this article was interesting to me because I was actually unaware that misoprostol can also be used intrauterine. So that's why I thought, okay, let's go through it and see what it says. And then towards the end, we said, okay, the one thing about the article, they didn't say whether in Cairo or in Egypt they're using misoprostol plus oxytocin as their first line for prevention. So that was a case for it would have been nice to know whether that's the actual standard of care or not. So then I said, okay, after this article, let's look at what is the current protocols and whether or not there is any, from my side, where I foresee any changes. So the figure 2022, that's the first line is still oxytocin only. It does, however, highlight that if you had to use oxytocin plus misoprostol, it might be more effective. But in in terms of the FIGO guidelines, oxytocin alone is still the first. And then also, WHO has a recent October consolidated guidelines, which include so it's a WHO and FIGO guidelines from October 2025. Oxytocin is still the first line. So that's where we are. Oxytocin only remains the first line, but it's nice to be aware that if you had to use the combination, it will be more effective, but it comes at the expense of more side effects. All right, that's my comments from that, and then I'll take any questions or comments before we move on. Yes, Dr. Nirmala.
Thank you very much for the presentation, and thanks for also putting in context the study, that data from the Saving Mothers. I just want to say that when you look at that Saving Mothers data, and it says there were so many deaths from bleeding after Caesar or at or after Caesar, that's actually an underestimate, because you've got this big category also of antepartum hemorrhage. Most of those antepartum hemorrhage deaths, they delivered and they died after they delivered. But it's classified as antepartum hemorrhage because they presented with antepartum hemorrhage. But many of them had Caesar died. So that's that's additional to the cases which are just classified as bleeding at or after Caesar. You see what I mean? So the contribution of Caesar to hemorrhage deaths is actually more than that figure suggests. I just want to say that, yes, you don't really have to refer to 2022 FIGO guidelines, because there's 2025, which is consolidated with WHO and International Confederation of Midwives and guidelines. And as you said, it's not recommended that you routinely add misoprostol. You said misoprostol addition may be more effective. The only thing that it may be more effective in is slightly reducing the amount of blood loss. But effective should be referring to the outcome, death, need for transfusion, those kind of things. There's no studies that have shown that the outcome in that sense is better if you add misoprostol. In fact, if you look at all the randomized trials where they use misoprostol versus placebo, for example, oxytocin plus misoprostol or versus oxytocin plus placebo, there have been more deaths in the misoprostol groups. So there isn't really strong evidence that you get better outcomes if you have misoprostol. Yes, there may be a few mils of less blood loss, but there's more side effects as well. So I don't really agree with doing this trial because I think the main thing they were trying out was this new method of administration of trial. I would have thought it's better to do intrauterine versus placebo. Then we'll really know whether it has any benefit, rather than comparing it versus sublingual, because we don't really have any evidence from this trial that adds to our knowledge about whether it's useful to do misoprostol addition to oxytocin. So that would be my point about. I think it's a sort of unusual approach to giving the misoprostol. Probably they do oxytocin plus intrauterine versus oxytocin and placebo.
For your last comment, I think a three-way trial might have been better. So you have the misoprostol plus the sublingual intrauterine and then the placebo. So that probably would have answered the overall question, whether because in the two groups, so you have a three-way, it probably would have given us a better answer. But for my things, I just wanted to see, and then when I read the article and the reference articles, you realize there's more studies out there that talk about the use of intrauterine misoprostol. So there is, but I also went a look around at a few. There's quite a lot of studies on PBH and misoprostol and oxytocin, different meta-analysis, but unfortunate always conclusions when it comes to the combination. There were always I looked at two meta-analysis. Yes, I agree with you. The conclusion was there's a reduced blood loss with the combination, but in terms of maternal mortality, there's actually no difference. All right, and can we, if there's no other questions, we're gonna move on. What's the time? And just on any questions or comments from the online audience? I don't see. All right, I don't see any questions or comments, so we're gonna move on to the next article. The next article Okay, thank you. I'm going to move on to the next article. The next article is a gynae article looking at the use of Dinogest in the treatment of endometriosis, presented by Dr. Mope. Dr. Mope, thank you.
Good morning. My article is about efficacy and safety of 48-week low-dose Dinogest treatment in patients with endometriosis, associated dysmenorrhea, a randomized open-label parallel group trial that was published in October 3, 2025 and written by Kyoko Kikuno in Japan. Endometriosis is a chronic gynecological disorder which is estrogen dependent and is characterized by implantation of endometrial tissue outside the uterine cavity. It is the common cause of chronic pelvic pain and infertility in women, affecting the quality of life negatively. Due to its chronic nature, it often requires prolonged hormonal treatment. Dinogest is a selective progestin that has been approved for endometriosis-related dysmenorrhea. Its trade name is Vicen. It is an oral progesterone and it binds to the progesterone receptor with high specificity and produces a high progestogenic effect related to the high circulating levels of the unbound molecules. It has a low risk of thromboembolic events and it can be used safely in older women 40 and above who are considered high risk for thromboembolism. It decreases endometriotic lesions through a number of biological actions. Long-term, it induces a hypoestrogenic and hypergestagenic local endocrine environment, causing a decidualization of the endometrial tissue followed by atrophy of endometriotic lesions. The objective of the study was to compare the efficacy and the safety of the low dose, with the 1 milligram per day, with the standard dose, the 2 milligrams day Dinogest for 48 weeks in patients with endometriosis-associated dysmenorrhea. Also, it was to determine whether the low dose Dinogest can be used as a safe and effective long-term therapeutic option. The study design and participants, it was a randomized open-label multi-center parallel group trial in Japan. A study was conducted in about 6 centers. The ethics protocol approval was obtained from the Clinical Research Review Committee of the Nagoya University Hospital. Informed consents were obtained from all participants prior enrollment. Study sample was 88 women with at least one ovarian endometriotic cyst confirmed by imaging. Other phenotypes of endometriosis, such as deep infiltrating or peritoneal lesions, were not systematically assessed and therefore may have been present in the study population. The sample size was calculated based on the two previous Japanese studies. The studies assessed the mean change in the visual analog score, and the non-inferiority margin was set to 15. The mean change in the visual analog score after 52 weeks with the 1 milligram Dinogest in that previous study was minus 52 with the standard deviation and 24.3 for secondary dysmenorrhea. The statistical analysis, primary analysis involved comparing the change in the visual analog score from baseline to 48 weeks between the two groups using the mean difference and its 95% confidence interval. Statistical analysis were performed using the R software version 4.1 or Foundation for Statistical Computing, Vienna, Austria. The study design and participants, the group was divided into two groups. 1 milligram a day Dinogest was given to 42 women and the 2 milligrams a day Dinogest to 46 women. The duration of the study was about 48 weeks and follow-up was every 12 weeks. The inclusion criteria, patients diagnosed with endometriosis and at least had a presence of one ovarian endometriotic cyst. They should not have had planned surgery. Patients with dysmenorrhea and those who plan to use Dinogest for 48 weeks. Patients should have had a regular menstrual cycle and aged 20 years older at the time of informed consent, and those who had given written consent to participate in the study. The exclusion criteria, patients who had difficulty reporting symptoms were not included, and patients with malignant disease, prior hormonal therapy used within 4 weeks of enrollment, and also difficulty in diagnosing endometriosis, and also when the patients were deemed inappropriate for the study by the primary investigator. Data collection and study procedures. Once eligibility was confirmed, patient data was collected using patients' questionnaires, laboratory tests, bone density measurements, imaging studies that were done. There was a pre-registration magnetic resonance done and an ultrasound. Data was entered into the electronic data capture system to facilitate enrollment and randomization. Research electronic data capture tools at the GP hospital was used. The treatment was started on the 2nd to the 5th day of the menstrual cycle following enrollment. Patients were randomly assigned to either get a 0.5 milligram Dinogest, which was the 1 milligram group, or 1 milligram, which was the 2 milligram group, twice a day. The first follow-up visit was 4 weeks post-enrollment and after every 12 weeks. Full assessments were done at each visit. At each follow-up visit, comprehensive assessments were conducted, including patient questionnaires, vital sign measurements, blood tests, and ultrasound examination to evaluate the size of the ovarian endometriotic cyst. And MRI was done before study enrollment to establish baseline imaging. Standard questionnaires were also used to assess pain and estrogen deficiency symptoms. The visual analog score was used for the dysmenorrhea-related pain, and the modified dysmenorrhea score was used based on the study by Harada et al. And for the estrogen deficiency symptoms, they were assessed using the Cooperman menopausal index. The analgesics were allowed to be used as needed for pain, and the dual energy absorptiometry was done twice at the start and end of the study to assess for bone density. The study endpoints or the outcome, it actually looked at two things, the efficacy and the safety. The primary efficacy point was the change in the visual analog score for menstrual pain, calculated as baseline score minus week 48 score. And in terms of the secondary endpoints, included the change in the dysmenorrhea score. The rate of the decrease in the size of the ovarian cyst assessed by ultrasound or MRI at baseline and at week 48, and the efficacy assessment included the changes in the visual analog score, dysmenorrhea score, and the cyst size at weeks 12, 24, and 36. In terms of safety, what was recorded were the low estrogen symptoms, fatigue, headache, palpitation, depressed mood, hot flashes, anxiety, and insomnia. These were symptoms that were not captured by the Cooperman menopausal index. And the changes in the Cooperman score, bone mineral density, and serum estradiol were assessed at baseline at 12, 24, and 36 weeks. This is the dysmenorrhea score, which actually included two things, the pain and the painkiller usage, and the degree which the pain was assessed. If there was no pain, the score was 0. If there was slight, the score was 1. If it was moderate, the score was 2. And the painkiller usage also, it was 1. So you would add, so the total score, it ranges between 0 and 6. This is the Cooperman menopausal index to assess for menopausal symptoms and low estrogen. So it looked the symptoms that were assessed, the hot and sweaty face, numbness in the lips, and loss of sensation, and all the others below. What was used to measure them? It was the degree. The degree ranges from 3 to 10, and the number that you would get, you will take the degree number and evaluate it with the evaluation. With the hot and sweaty face, the evaluation was 4, and then numbness in the limbs and loss of sensation, it was 2. So the scores were classified as follows. If the symptoms were mild, the score will range between 16 and 20. Moderate, they will range between 21 and 34. If the symptoms were severe, the degree, it was more than 35. This is the participant flow chart. In this diagram is showing that there were 88 patients that were enrolled in the study. So a total of 88 patients were recruited and were randomly assigned to receive either 1 milligram a day of Dinogest or 2 milligrams a day. One patient actually withdrew from the study, then they were left with 87 patients. So on the Dinogest 1 milligram group, we had about 42 patients, and on the Dinogest 2 milligram, we had about 46 patients. The patient that withdrew, then the number was left with 45. And then after they did a safety analysis, there was another withdrawal afterwards on the 2 milligram group. One patient withdrew because there was a missing data of the visual analog score, and then the number that was left was 44 when they continued with the study. From there, 8 patients also withdrew from the study. At the end, they were left with 36 patients. So the reason for withdrawal for these patients is either they missed the primary endpoints, or there was one case where there was a patient with a malignant lymphoma, and the other 2 patients discontinued because of personal reasons, and the other case was lost to follow-up. And one of the 2 patients actually had unresolved genital bleeding. On the other side, on the 1 milligram group, 3 patients withdrew afterwards. One was ineligible after randomization. The other patient had menopause before treatment, and the other one was missing all the visual analog score data. And then there were 39 patients from there, 4 withdrew from the study. At the end, we had about 35 patients who continued. In terms of the results, this is a demographic and the clinical characteristics of the patients. It looked at various variables: the age at informed consent, the body weight, the body mass index, the uterine transverse diameter, the dysmenorrhea score, the baseline pain, the hemoglobin level. So if I look at this study here, the table summarizes the baseline features of all women. The variables are presented as either mean, standard deviation, interquartile range, and visual analog scale. So most variables, they were more than, the p-value was more than 0.05. So it shows there was no statistically significant difference between the groups, indicating that the study groups were well meshed. Results in terms of the primary endpoint. So in terms of pain reduction, both doses reduced pain significantly according to the visual analog score. In the 1 milligram group, the mean change from baseline was 44.6 millimeter with the 95% confidence interval of 35.17 to 54.09, whereas in the 2 milligram group, the mean change was 54.19 millimeter and 95% confidence interval of 44.75. So the between group difference was minus 9.57 with the confidence interval of minus 22.7 to 3.6. Although the 1 milligram group showed pain reduction comparable to that of the 2 milligram group, the lower bound of the 95% confidence interval was minus 22.7. For the between group difference, it did not exceed the predefined non-inferiority margin of the minus 15 millimeter. So therefore, the non-inferiority of the 1 milligram dose could not be statistically confirmed. Both groups improved dysmenorrhea scores and reduced cyst volume. This graph here shows the visual analog score where they assess the pain of the patient. So it uses the confidence interval. The patients who had the 1 milligram, they are using the blue dotted line, and the 2 milligram group is using the red solid line. And the error bars are indicating the 95% confidence interval. And this is showing the patient from baseline, 12 weeks, 24 weeks, 36 weeks, and 48 weeks. So it's showing that at the end, at 48 weeks, the greater reduction of pain was more into the 2 milligram Dinogest group than in the 1 milligram group. In terms of the secondary efficacy point, in terms of the dysmenorrhea score, the 1 milligram group had the changes were minus 2.09 with a 95% confidence interval of minus 2.67 to minus 1.51, and the 2 milligram group had a minus 2.44, and the confidence interval was minus 3.06 to minus 1.86. So the between group difference was 0.36. It indicates that there was no statistically significant difference between the two groups, though the 2 milligram groups, it reduced the pain more than the dysmenorrhea more than the 1 milligram group. Also, the study looked at the ovarian endometrioma, which was also one of the criteria for diagnosis. So when they were looking at the reduction, the mean absolute volume of the cyst reduced at minus 0.37 in the 1 milligram group, with the confidence interval of minus 0.62 to minus 0.12. And in the 2 milligram group, it was the reduction was minus 0.5 with a confidence interval of minus 0.81 to minus 0.18. So the between group difference was 0.13. So there was no statistically significant difference observed. So the reduction rate in the cyst volume were 42.1% in the 1 milligram and 64.2% in the 2 milligram group. So the corresponding mean reduction rates were 64% in the 1 milligram group and 78.6% in the 2 milligram groups using the IQR. When looking at the hormonal effects, the 2 milligram group maintained the serum estradiol within the range of 30 to 50 pg per ml. The 1 milligram group had a higher median E2 levels of 63 pg per ml, contributing to better bone density preservation. So the 2 milligram group bone marrow density was minus 2.85, and in the 1 milligram group, the bone marrow density was the bone mineral density was minus 0.46%. So the 1 milligram Dinogest group may be actually a safer long-term option for those at risk of bone loss. In terms of the bone effects, they also looked at the bone mineral density changes at the lumbar spine. In the 1 milligram group, the changes were 0.005, and the 2 milligram group was 0.024. There was no significant differences in both groups, but there was less bone loss with the 1 milligram dose. In terms of safety and adverse events, there was no serious adverse events reported. There was a hypoestrogenic symptoms. The hypoestrogenic symptoms were mild, the headache, fatigue, and hot flashes. In terms of treatment completion, the 1 milligram group, 95.2% of the patients completed the study. And in terms of the 2 milligram group, 84.8% completed the study. The more discontinuation was in the 2 milligram group due to side effects. Milligrams, both groups showed significant reduction in menstrual pain. the statistical non-inferiority of the 1 milligram could not be confirmed for the primary outcome. The 2 milligram provided faster and slightly stronger pain relief. The 1 milligram had better tolerability and less bone mineral density loss. The bone mineral density Z scores were not consistently available and therefore were not analyzed, which was actually a limitation. Both groups showed reduction in endometriotic ovarian cyst. The 2 milligram reduces lesion size by 66 to 79% over 6 to 12 months, in keeping with previous studies. The 1 milligram group also achieved significant reduction despite lower estrogen suppressive effect. The clinical implication, the 2 milligram a day Dinogest is preferred for patients who need rapid pain control, and the 1 milligram a day Dinogest is actually suitable for long-term therapy or patients at risk of bone loss. Support flexible patient-centered dosing approach in clinical practice is important. In terms of limitation, this study was a small sample size with a total patients of 88, though other patients withdrew from the study. And as an open label design, there's potential bias in pain reporting, and the study population only was limited to ovarian endometriosis. The 48-week duration may not capture long-term bone outcomes. In conclusion, the 1 milligram a day Dinogest effect is effective but slightly less potent than the 2 milligrams. The 1 milligram a day showed better safety and bone preservation. Those selections should balance efficacy and safety. Further large-scale trials needed to confirm non-inferiority.
Thank you. This is unusual, but I am just going to ask you one or two questions, Dr. Mopem, because I taught you basic statistics yesterday. So I'm just going to just ask you to just give me a simple interpretation of this confidence interval and the p-values. Just go to one of the slides. You can choose whichever one you have that has a p-value and a confidence interval. All right, and I want you to explain to me in simple terms. How do you interpret it? All right. So let's just go to so I'm looking at the last line, all right, that's showing us the p-value of 0.368. So let's assume I didn't show you that confidence intervals. Would that p-value be statistically significant, yes or no, and why? So that's the first question. Secondly, once you have answered it, then I would want you to look at the confidence interval and interpret that confidence interval for me, all right?
It's not statistically significant because the p-value here is more than 0.05.
Good. Then look at the confidence interval and tell me why that confidence interval is not statistically significant. If you didn't know that the p-value of more than 0.05, that indicates statistically significant. So let's assume you didn't know just the p-value and look at the confidence interval and tell me how would you know that confidence interval?
Because here the confidence interval is minus 0.47 and then it crosses the line of no effect because it becomes positive. It's positive here, 1.19.
So it moves from negative to positive. So it has to be either both minus or both positive. The moment it crosses from a minus to a positive, we know that it's not statistically significant. All right, good. You seem to have done some homework, so I'm not going to ask you about mean, median, and interquartile length. All right. So I chose this article specifically because after I read it, I thought it has simple basic statistics because she has not done any. This is her first journal article, so I gave her to go and do the article and then do some homework in terms of basic statistics. But I don't have too many questions in terms of the article itself, just to say that in this country, in terms of endometriosis, we only have Vicen. Vicen with two. We have two that I'm aware of. We have two tablets that have Dinogest. One is Vicen. Vicen has 2 milligram Dinogest, and the other one is Creda. Creda has estradiol valolate and Dinogest. In terms of which one do you use, I have my own way in which I choose. Depends on the. For me, it depends on what's the primary symptoms in terms of what's the patient presenting problems. Is it endometriosis with pain? Does a patient desire an effective contraception or not? And thirdly, does the patient has irregular cycle or not? So for me, if the patient has severe symptoms and the primary concern is endometriosis with pain, probably Vicen is the way to go. You just have to counsel them. It's not an effective contraceptive, and sometimes they can have irregular bleeding. But however, if a patient has mild to moderate symptoms, and then they also desire an effective contraceptive, or they have an irregular bleeding, then I tend to maybe start first with Krela. So unfortunately, both the two tablets are costly. Vicen is about 500 rand per 20 for the one pack for a month, and Krela is about 250. I did not confirm, but I think there might be a generic of Vicen and a generic of Krela. So whenever there's a generic generally tend to be slightly cheaper. Other than that, just want to quickly look at the time, and then I'm just going to take, I got 1 or 2 minutes. Any questions or comments from the floor? No questions or comments on the online audience.
Can you all hear me? This is Dr. Ramford.
Dr. Ramford, oh, please come in.
Yeah, now certainly, you've got to understand that Cleara has never been marketed as an agent for use with endometriosis. For many of us, when we used it in the younger patients, especially when we suspected endometriosis and they required cycle control, the company was very clear that there is work that has been done, that the estradiol component of it actually, as you're aware, rightfully said initially, that endometriosis is an estrogen-driven disease. So certainly you can get flare-ups even with a small dosage of estrogen. So if patients are requiring requiring contraception on the background of endometriosis, we still use Vicen and consider barrier contraception as first line. So I think we must be very clear that Cleara is not a drug. Even the company will tell you that. Right? The company will also tell you that it has been marketed for endometriosis, irrespective of the age of the patient and irrespective of the patient requiring pain alleviation in the background of wanting contraception. So that's just a word of caution.
Well, thank you, Dr. Lamford. I hope everyone here. Just one question, Dr. Lamford, from my side.
Yeah.
I've seen that some people would, even when you look at the package insert and the information on Vicen, they would say should not be used with another hormonal contraceptives. But some people would suggest that, would say if a patient is looking, has the primary problem is endometriosis, but they also do not just want to rely on barrier, you can consider the use of it and combine it with another hormonal contraceptive. So, for example, put a Mirena IUCD. You definitely can't put a copper IUCD because that is going to worsen it tends to worsen the pain. But have you seen, or in your experience, have you had to combine Vicen with Mirena or Vicen? Because that the issue with combining it with Evra will be the fact that also Evra could cause flare of the endometriosis. But have you come up to instances where you could combine Vicen with Mirena on the basis that Mirena is locally acting, and therefore there will not be an overdose of the progesterone, and therefore you would not be necessarily be concerned about potential side effects and complications of systemic progesterones?
Yeah, I think you got to, as you rightfully mentioned, Dinogest is a progesterone, right? So that falls under the progesterone category. So you cannot use any other alternative progesterone with it. So even using Mirena, you can't put the patient on Dinogest and also put in a Mirena. What we advocate is barrier contraceptive, or in the absence of barrier contraceptive, is an IUCD. Now you can argue the point, the IUCD doesn't give you pain. It's used as a contraceptive. It's endometriosis that give you pain. On the other hand, we do know that one of the treatment of endometriosis is the IUCD, the Mirena. So in that category of patient, who's having requiring contraception in the background of endo, we can actually just put in a Mirena and monitor the patient. You don't need to put the patient both on Dinogest and Mirena.
All right. Thank you very much. Thank you very much from everyone. If there's no additional questions or comments, thank you and have a good day.